The planning process for Sarah Lynn's radiation therapy journey begins in the CT scan room. This CT resembles a diagnostic CT, but for the radiation oncology department, we use it to set up the patient into the position they will be in for each of their radiation treatments.
Before we bring the patient into the room, we set up the table with immobilization devices. The breastboard makes the position easy to reproduce in order to deliver accurate treatments. Any adjustments can be made with the bump stopper and the elevation of the board.
The knee sponge alleviates back strain, and the headrest ensures comfort to the patient's head. We cover it all up with a sheet. Hi, I'm your CT Tech Paige, and today we're going to be taking a scan of you and preparing you for treatment. Can I have your full name?
My name is Sarah Lynn.
And your date of birth?
May 13, 1973.
Amazing. We can head on in. After adjusting the patient's immobilization devices, we bring the table up and tell the patient to lift her arms. It's important to let the patient know that they shouldn't move for the purpose of the CT scan.
We align the lasers to the proper anatomical structures.
We place little stickers where the lasers intersect on the sternum and on the right and left sides of the patient. These BBs will be visible on the scan.
Here we bring the table in to where the scan will begin, and then we zero the table.
Then we move to the console area and take the actual CT scan.
After the scan, gloves are needed to remove the stickers and give the patient some tattoos. The number of tattoos vary depending on departments. They are used as reference marks during the treatment for patient positioning.
We bring the patient down and inform them that their simulation process is over. The scan will be sent to dosimetry, where they will develop a unique treatment plan. The patient will then receive a call once their treatment plan is finalized. Then the radiation treatments will begin.
A lot of things goes behind cancer treatment behind the scenes. Dosimetry is one of them. This is where we're going to contour the patient with the CT we acquired. In this application, we are able to see the inside of a patient layer by layer. Our job here is to outline and identify every major organ surrounding the cancer. We contour organs at risk. They are at risk because to treat a patient in radiation oncology, X-rays have to pass through a certain amount of normal body tissue to reach the cancer. Different types of side effects can occur depending on what organs receive the radiation. If we're not careful, permanent damage can be done to structures like the heart. However, doctors in radiation oncology create treatment plans in ways as to avoid this as much as possible. Here you can see an example. Techniques like splitting up the beam and avoiding certain parts help reduce the chances of having side effects. This is better than using a single powerful beam. Going back to the application, there are a bunch of tools on the side to help us in contouring. Changing the window width and level helps us differentiate tissues just like this.
All our treatments are given using a linear accelerator, or as we like to call it, a LINAC. This device has a table where we position the patients using lasers and the tattoos that were made at CT.
During CT, the patients will be marked with tattoos on their body, and then we might need to make further adjustments depending on the accuracy as to where the tumor is specifically placed, and that is called ISO shift. And after we do the ISO shift positioning, we then cover their patient's body up for their dignity.
On the LINAC, we have onboard imaging devices that allow us to take mini X-rays or mini CT scans of the patient. So our next step is to image the patient so that we can properly visualize the internal organs and bones, which will later help us properly line up the patient to the millimeter on their tumor.
So the images that we take from CT, we use every single day during treatment as a reference image, and this is called DRR. And with every single treatment, we take an image after positioning to match the two images together and to ensure that the position of the patient is correctly and exactly where it's supposed to be within each treatment before we start the treatments.
The last element that could improve our accuracy further are MLCs, or multi-leaf collimators. These can help shape the beam and help us match the shape of the beam exactly to the tumor. So these can take really irregular shapes and really get us really precise on the tumor.
The utmost importance for IGRT, which is image-guided radiotherapy, is that the patient is positioned properly for utmost accuracy and that the MLCs are in the right space.
In conclusion, an accurate delivery of treatment is our #1 goal. By doing the CT scan at the beginning, we can get a general idea of what the patient's organs look like and create a plan with dosimetry where we see everything that's going to be radiated and we come up with a specific plan for the patient. During the treatment delivery, we have tattoos where we can get a general idea of where to set up the patient, and then we take images with a cone beam CT or KVKV, which are onboard imagers, where we can see the insides of the patient and really properly line up to the target. We also have an MLC, which can shape the beam irregularly so that we could really get that millimeter accuracy for the patient.
So that was some insight as to what goes on in the Radiation Oncology Technology Department, and that is just one step out of the many in a patient's cancer journey. Thank you.